Welcome everyone to today's CIRA Talk. My name is Dini Arsono. I'm Assistant Director of the Clinical and Health Services Research Core at CIRA, the Center for Interdisciplinary Research on AIDS at Yale University. And today's talk is titled Reducing HIV Transmission Among People Who Use Drugs, Rich Clinic Implementation of Low Barrier Pre-Exposure Prophylaxis and Medications for Opioid Use Disorders. So welcome, everyone. So today's seminar is being recorded for future viewing. The slides and recording will be available at CIRA website, as shown on the screen right now. And our website is at the cira.yale.edu. For everyone who are new to CIRA, I would recommend visiting our website and also sign up for our electronic bulletin or newsletter, where we promote and share information on recent publication projects, people affiliated with CIRA, and opportunities that are taking place and will be held at CIRA in the next few months or so. So please visit our website and browse around for many resources available for everyone. And this is a reminder for an upcoming event sponsored or organized by the New England HIV Implementation Science Network. So the network is a collaboration between CIRA and the Providence Boston Center for AIDS Research, CIFAR. So this event on June 29th at 10 a.m. is a community organization open house, which will be held virtually. And I will post a link to register in the chat in the short moment. So this open house will feature 4 organizations located in New England who work to address HIV and to provide support for HIV and harm reduction programs. And and I will share the link shortly. So today's talk will feature a research presentation by Dr. Jessica Taylor, and will be followed by a discussion and Q&A session. Throughout the seminar, please use the chat to submit questions and comments. If we run out of time, I will save the chat and send it to all the panelists for follow-up. And in addition to that, so I will introduce Dr. Jennifer Edelman, who will moderate today's talk. So Dr. Edelman is Associate Professor at the School of Medicine and School of Public Health. She is certified as an internist, HIV specialist, and in addiction medicine. Her research focuses on optimizing HIV prevention and treatment in the context of substance use, including opioid, alcohol, and tobacco use. At CIRA, Dr. Edelman is the Director of the Clinical and Health Services Research Core. And with that, I will turn over to Dr. Edelman. Thank you.
Thank you so much, Dini. Thank you all for being here. I'm really looking forward to this hour that we have together. And thank you, Dr. Taylor, for joining us and sharing your time and expertise with us. Dr. Taylor is an assistant professor in medicine and general internal medicine at Boston University Medical Center and Boston University School of Medicine. She's board certified as an addiction specialist. She attended Mount Sinai School of Medicine and completed her internal medicine residency in Boston at Beth Israel Deaconess and Harvard Medical School, where she also served as chief resident. She has been a real leader in innovative models of care delivery to address substance use, HIV, and viral hepatitis, and really leading and innovating low barrier treatment models to reach most vulnerable populations. We're really excited to hear about her work today that I want to jump us right into. We're also really excited to welcome Dr. Jamie Meyer, who's here at Yale, Associate Professor of Medicine and Infectious Disease and Epidemiology in chronic disease at Yale School of Public Health. Dr. Meyer does work focused at the intersection of HIV and substance use with a particular interest in individuals who have had criminal justice involvement and among women, and has had multiple sources of NIH funding in that area. And then Dr. Michael Virata will also be serving as a discussant with Dr. Meyer. Dr. Virata has been a real leader in promoting delivery of services for patients with HIV and promoting HIV prevention across our health system. So without further ado, Dr. Taylor, we look forward to your talk.
Wonderful. Thanks so much. Thanks so much for the chance to be here. I'm going to screen share. Let's see.
As you're sharing screen, I just want to encourage everybody, please put questions and comments in the chat box. We'll be monitoring that.
All right. Did that do the trick with seeing slides? Okay, excellent. I'll just make sure I have the chat up. All right, so I'll jump right in, but thank you again for the chance to be here and have this conversation. Really welcome questions and comments as we go along. And so today we're going to get the chance to talk about addressing HIV prevention in the Bridge Clinic setting, which is a low barrier substance use disorder treatment setting. In terms of disclosures and funding, so I have no financial conflicts to disclose, but do want to acknowledge the support that our program receives from the Department of Public Health, both in terms of the Bridge Clinic itself and also our overall HIV prevention services at Boston Medical Center. And some of the analyses that I'll show you today were supported by one of our addiction medicine fellows, Dr. Paul Christine, and his funding is listed here as well. Obviously, you have to lead by starting with a big thank you to our teams, both our Bridge Clinic teams, our public health teams, and also want to thank Dr. Angela Bazzi, who co-presented some of these slides with me a couple months ago and has done slide review. And also just want to say that we will be talking about off-label medications for HIV prevention for people who inject drugs. The reason for that is that there are actually no on-label, no FDA-approved medications that have a specific FDA indication for HIV prevention for those at risk due to injection. So a couple of goals as we think about the next 40 minutes together. We'll quickly describe the epidemiology of HIV impacting people who use drugs and people who inject drugs. Cover HIV prevention tools that are evidence-based in this population, including specifically HIV pre and post-exposure prophylaxis, and also medications for opioid use disorder. And really want to hone in on medications for opioid use disorder, specifically methadone, as an incredibly important HIV prevention tool. And then I'm hoping to share some of our experience over the last 6 years in our Bridge Clinic, FasterPass, implementing PEP, PrEP, as well as low barrier medications for opioid use disorder treatment. So, just framing for this talk, I think it is no surprise to this group, and so I won't belabor the point that people who inject drugs remain at incredibly high risk of HIV infection. For the first time in decades, we're actually seeing increases in HIV incidence in this population. This is driven by the fentanyl and polysubstance use disorder crises that we know drive frequent injection events, injection frequencies that mean that we really just can't put enough clean injection equipment out into the communities to avoid reuse and sharing. And also by the structural factors that we know are huge contributors: homelessness, structural racism, incarceration, really interrupting access to harm reduction and treatment services. I practice in Massachusetts, and I'm sure it's familiar to you all in the region as well that we've been dealing with HIV outbreaks, several in our state, and an outbreak actually in Boston that's ongoing. And the backdrop here is trends that are really incredibly alarming. So when we look back to 2012 compared to data from 2018, we had seen an 88% increase in new HIV infections among people who inject drugs overall, and a 450% increase in young people who inject drugs under age 30. Really, this is something that is, I've never seen it before in my admittedly short career, but just feels very, very much as though we're still in a crisis. And we've been here since 2017. So that was when the DPH initially alerted to a cluster of new infections in Lowell and Lawrence, urban areas north of Boston. And then in 2019 was the first alert about a cluster in Boston that was new cases starting in late 2018. It has really been ongoing. And so what this has looked like for us, specifically in Boston, is just ongoing high transmission. This graph goes from late 2018 to 21, and this trend has continued. And at Boston Medical Center, like where a lot of you practice, we're really a safety net setting. And so we see a lot of new HIV infections. And our experience really reflects statewide and citywide trends, where back in 2017, we had not yet seen an increase in new injection-associated infections. By late 2018, we were really seeing the beginning of the cluster. 2019, ongoing high transmission. And then we had a year that we really hadn't seen before in 2020, with 25 new IDU-associated HIV infections only at our medical center. Another year of ongoing high transmission last year. And then here in 2022, we're feeling a little bit nervous because we started the year with a cluster of 5 new cases in 6 weeks, just among people who inject drugs, and really were frankly panicked that we were seeing the tip of another iceberg related to gaps in testing during the pandemic, related to local factors like dismantling of tent encampments in our neighborhood that have displaced people from services and care locations. And so far that seems to have been a bit self-limited, that small cluster, but we're concerned that we're not testing enough people and that 2022 still looks like we're on track for another year of very high transmission impacting this population. I'll just also point out that year to date at BMC, about 1/3 of our cases have been IDU associated, which is really not typical for us as we look back 5 years ago, 10 years ago. So I mentioned lack of screening because this is one of the things that has us very concerned. We've looked at our data and we're a pretty high volume testing center when we look at all of our emergency department, our inpatient units, our outpatient units. And we saw a really dramatic drop off in HIV screening during the first wave of the pandemic that actually took an entire year to rebound. And so that has us concerned that we're still catching up, that we have not yet addressed the profound needs for screening that exist in our population. And we're still working through data from early 22, but we're concerned that Omicron may have had a similar impact, from, not as dramatic, but we know that with some of the operational changes related to the Omicron surge, we were doing less testing. So that's our backdrop. We are practicing in a region with very high transmission among people who inject drugs. And I thought I'd just speak for a moment about the evidence-based strategies that we have at our disposal that we can leverage. I'll say a brief word about PrEP because, again, this group doesn't need convincing. It works. So PrEP is an incredibly effective HIV prevention tool. We have a single randomized control trial, the Bangkok-Tenofovir study, that now actually it's about 10 years old, which is really pretty remarkable. But what that study showed was that daily oral tenofovir, so it was not co-formulated in that trial, decreased HIV incidence compared to placebo by about 49% overall, and then by higher proportions in people who had detectable drug levels or near perfect adherence. So incredibly effective, not 100% effective. PrEP is not 100% effective in any population, but really an incredibly potent HIV prevention tool. And the other point I'll make is that it's recommended. So I listed the CDC here, the USPSTF, you look internationally, WHO. This is really a recommended strategy that we should be offering to our patients with injection-related risk as well as sexual risk. I mentioned we have a single RCT though, and that's a problem. And the reason that I don't have more RCT data to share when I give talks like this is that people who inject drugs and other people with substance use disorders have been incredibly effectively excluded from HIV prevention drug trials over the last decade and beyond. And these include trials when we think about HPTN 083 and 084 of long-acting cabotegravir, for example, that have excluded on the basis of hepatitis C antibody positive, which if anyone can make an argument for a biologically plausible reason that would interfere with the PrEP trial, please share. I haven't been able to come across one. But that really effectively excludes people with active injection substance use and people with past substance use, as well as others. Trials often exclude on the basis of active SUD, active substance use, investigator opinion. And so we can see a lot of stigma and bias creep into trials that results in our patients not being well represented and us having to make clinical decisions on the basis of expert opinion or choosing off-label options, which is really really an inequity as we think about the quality of evidence that our patients deserve. People who inject drugs have also been underrepresented in community-based research, implementation studies. And I think what we see is that the care continuum for this population remains incredibly understudied. So the data that are out there often focus on initiation and uptake, and we know much less about retention, PrEP persistence, and sort of further down the care cascade, discontinuation of PrEP eventually. And this is a slide from Dr. Angela Bozzi's team at UCSD. Dr. Joel Earlywine created it. It's just a slide that demonstrates the number of publications available in PubMed on PrEP that address various risk populations. And you can see that over time, we've continued to have a very high number and an increasing number of PrEP studies addressing populations such as men who have sex with men, people with heterosexual risk. And the number of studies addressing people who inject drugs has really remained fairly flat. So all of this coming together to give us not the same robust randomized controlled trial quality data that we have in other populations around PrEP. That's really a shame because the need among people who inject drugs is extraordinarily high. We can look at various populations across the country, but just locally where I practice in Boston, survey data that was done in 2018 demonstrated that over 90% of people injecting drugs in Boston had a PrEP indication. And this was really interesting work because it was a little bit different than some of the other work I've seen that really demonstrate true overlap of sexual and injection-related risk. In our cohort, people are reporting more injection-related risk and certainly also sexual risk in about 25% of people who responded. But it was interesting to me to see that the injection-related risk behaviors seem to be more of a driver of PrEP eligibility than sexual in our cohort. And so, why is it that PrEP is so underutilized? So if people aren't familiar with Dr. Katie Biello and Dr. Angela Bazzi's qualitative work, I think it's just been incredibly illuminating to figure out the different levels of barriers that our patients face. So we can think about individual level barriers, which include low PrEP knowledge. Just want to point out that that is not a patient side deficit. That is really an issue with the medical system and us as providers and treatment teams and how we have delivered or not been successful in delivering the right messaging around PrEP. It includes interpersonal barriers, the profound experiences of stigma and bias that our patients experience when they seek care for injection-related issues or their SUD. And then, of course, structural barriers, the systemic racism, incarceration, homelessness, poverty, lack of access to coverage, insurance coverage. So this could be, I think, an entire talk, but just want to name that the barriers are really substantial. And the result is that when folks have done systematic reviews looking at PrEP uptake in people who inject drugs, uptake is in the range of 0 to 3% for eligible people, which is really just completely abysmal and not even scratching the surface of need. It's not all bad news though, because there are increasing data coming out demonstrating what helps and what allows us to do this well and deliver PrEP effectively and in a patient-centered way to people with substance use. And just locally in Boston, 2 papers that I wanted to highlight from our colleagues at Healthcare for the Homeless that are teams that I just so admire and have really inspired how we're trying to practice in our Bridge Clinic, addressed their PrEP program for people experiencing homelessness, many of whom experience street homelessness. And what they did is qualitative interviews, asking participants what worked well, what facilitated their experience. And what they named was a patient-centered approach, trusting positive relationships with providers that demonstrated true investment in their health, low barrier services. And what does that mean? So what do we mean about low barriers? So in this context, it means drop-in services, walk-in services, no issues with turning up late or not the day that was planned or unexpectedly. Ability to get a same-day prescription, so none of this multi-step sort of multiple hoops that we know our patients face in a lot of traditional care settings. Lots of medication support, ability to do shorter prescriptions, to support storage, to avoid challenges with medication loss and theft. And then, also just engaging people that are involved in the program to support one another and do peer-to-peer education. And so the graphic that's here is a graphic that was designed by the program by one of the participants. And I think this team has just done a really great job of engaging people who stand to benefit from PrEP and really designing the services in a way that is community-centered and culturally humble and appropriate. And their data bear that out. So looking at the quantitative outcomes from the program of Boston Healthcare for the Homeless, what they found was that initiation and retention rates for people referred to their PrEP program were actually comparable to other populations that have many, many fewer barriers. And that their PrEP persistence at 6 months was 44%, which is really pretty comparable to the numbers that we hear shared in other populations. 50% persistence at 6 months is sort of a standard in the literature. So really pretty compelling work. And I think should give all of us hope that the barriers we talk about, they're not insurmountable. We just have to dedicate the resources and design the programming in a way that's appropriate to get patients the care they need. And so shifting gears for a minute to talk about medications for opioid use disorder. This is something that I think I have increasingly been trying to be aware of in my own work and in our work in the Bridge Clinic is just recognizing the effectiveness and the potency of medications for opioid use disorder in decreasing HIV incidence. And so when we think about our meds for opioid use disorder, methadone and buprenorphine are first-line treatment options. They both reduce opioid overdose and all-cause mortality. And methadone in particular has a lot of data demonstrating decreased HIV incidence, as well as decreases in HIV risk behaviors like sharing injection equipment and sort of other risk behaviors. And I just want to point out, we've known this for a long time. So this feels like a bit of a new focus for me in 2022 as I really try to think a little more holistically about HIV prevention in our program. But this is not a new idea. So data go back to 1993. These are observational data, but demonstrating a significant decrease in odds of HIV acquisition among people engaged in an OTP compared to people with opioid use disorder not engaged in OTP. No surprise, but I think really important for us to center this and focus on medications for opioid use disorder and addressing the overdose crisis that really has never been scarier than it is today, and also the ongoing high HIV transmission in our community. And methadone to us feels more important than ever with the challenges that people are facing getting on buprenorphine in the era of fentanyl and just challenging inductions with precipitated withdrawal. We as a Bridge Clinic have historically focused on buprenorphine, but have shifted gears just in recognition that buprenorphine isn't working as well for everyone as it has in the past. We can still get people onto buprenorphine that want to be on buprenorphine and really work hard to help patients get on the medication that is the best fit for them. But I think we all need to be asking ourselves how we can be facilitating better access to methadone from a clinical standpoint, from an advocacy standpoint. And so we'll talk a bit more about methadone later on. And also, no surprise to this group, it's too hard to get onto methadone. The punchline is we have extremely stringent federal requirements for the licensure of OTPs, for the day-to-day operations of OTPs, for dosing, for counseling requirements, et cetera, that really just make this incredibly effective treatment inaccessible to many people. We don't have enough OTPs. There are certainly models across the country of very low barrier OTPs. Many are, on the other hand, are actually fairly high barrier. And even if the goal is to be lower barrier, they may just be at capacity, not have adequate capacity for new patients. They may be geographically distant from where patients are located. So just a lot of challenges getting people a medication that I think is arguably our most effective for opioid use disorder, and also, like we mentioned, very effective for HIV prevention. And huge issues with inequity in terms of racial discrimination, socioeconomic inequities, and who is able to get onto an OTP and stay retained. And I should say OTP is opioid treatment program, which is also sometimes called methadone clinic. So that brings me to what we can do as providers that are outside of an OTP to make methadone access easier. So of course we can look into being licensed as OTPs, and our team is doing that. And as people here who work in OTPs know, it is an incredibly challenging process that has a lot of layers. But in the meantime, there is a legal provision that allows the administration of methadone outside of OTP licensure. And this is called the 72-hour rule. I think the theme here today is what's old is new, because this is actually not a new rule. But this is a statute that allows people who are not OTP providers to administer a narcotic drug. It does not specify methadone, but uses general legal language. We don't say narcotics clinically, but a narcotic drug for up to 3 days to treat opioid withdrawal while linking to ongoing care. There are a number of provisions. So in this initial form, it does not allow take-homes. The medication has to be administered in clinic, can't be prescribed, no more than 1 day's dose administered at a time. And this is a rule that I think has had a lot of kind of urban legend around it or lore, where we'd always thought this was something that was limited to emergency departments. And in emergency departments, it's primarily used in settings of natural disasters. So during Hurricane Sandy, for example, there was a lot of examples published about OTPs having to close due to the hurricane, and then patients seeking treatment in local emergency departments. Sometimes in the case of a medical emergency or a patient who is being admitted to the hospital, an emergency department might leverage this rule. But to be honest, not very much has been written about it or its use or evaluating it as a practice. And so probably a year and a half ago at this point, we started conversations with our hospital council about whether as an outpatient bridge clinic, we could meet the requirements of the statute and be able to practice administering methadone in a way that was compliant. And we were fairly surprised, or pleasantly surprised to figure out that we actually did have the infrastructure to do it. And that included both the medication infrastructure, so a medication dispensing cabinet, for example, a way to track medication administration in the medical record, and have a continuous supply of a controlled substance, track controlled substance quantities and administration. And also the infrastructure to link to ongoing care, because really to be practicing in compliance, we have to be able to make that linkage to the next step in a patient's care. We don't just want to be doing 3 days of methadone and then turning people back out without a care plan. That would potentially increase their risk. But bridge clinics have pretty solid community relationships and referrals networks. And so we thought that we'd be able to build on those and potentially create pathways for direct admissions to opioid treatment programs within 72 hours. So what did this look like? And I see a few things coming up in the chat, but I'm not catching them in real time. So feel free to interject if there's something I should stop to answer while we go.
There's just thanks, Jess. There's a lot of discussion around how fentanyl is impacting initiation of treatment, but I think maybe we can save that for the discussion.
Great. So I'll share a little more about what our bridge clinic looks like, because bridge clinics at this point are a model that's been around for really 5 to 10 years. Many of them look very different. Ours is a joint internal medicine, emergency medicine initiative. We opened in 2016, so we're just about to finish our 6th year. And we are located in the hospital. That has a lot of implications. It means that we have access to a lot of institutional resources, including the medication cabinet to administer methadone, which allows us to do some of the work that I'll talk about. It also means that patients have to walk in the front door of a hospital, pass a security desk into a pretty traditional healthcare setting in order to come to see us. And we know that that's a barrier. We are located in a space, I don't know if anyone on here has visited Faster Pass, but picture an old break room for the phlebotomists. That is now our clinic. So the phlebotomy break room was converted. We have 1 exam room and a consult room, and we've got a little tiny waiting room that has 5 chairs. And then we have a little desk that our care coordinator sits at. So petite little space, we try to do a lot with it. We saw a little over 1,100 patients last year for about 4,000 visits. So it is a small space that does a pretty high volume. We're open 7 days at this point. And we usually see our patients an average of 3 times. Wide range. There are some people that we're seeing several times a week for many weeks. Our longest standing patient started with us in September of 16, and for a variety of reasons, we're the right care setting for her. And so we certainly do have people that stay with us and don't transition, but a majority of our patients are with us on an order of weeks to months, and then we transition them to a long-term care setting. And I included here just a quick snapshot of what our team looks like. We're really anchored by a nurse care manager model, and then have providers who rotate through. We have all told, including moonlighters, about 2 FTE of providers to cover 7 days of services, and then several patient care coordinators, a manager, an incredibly important emergency medicine pharmacist that helps us run the medication pieces of our program, and large per diem staffing pools. So happy to take questions about how this house of cards kind of hangs together, but we've grown a lot, and it's been cool to be able to add folks as the needs of our patients have grown and as we've understood them better. And so what do we offer? So this slide just has a brief overview of the medications that we offer for substance use disorders. For opioid use disorder, historically we offered the formulations of buprenorphine, as well as naltrexone, although don't do that very often. Most recently, we've added methadone for opioid withdrawal management under the 72-hour rule. And then we have medications to treat other use disorders on or off label. And because of the COVID public health emergency, we've been able to do some of our buprenorphine care by telemedicine. Now, other services targeting HIV prevention. So we offer low barrier HIV testing. And what do we mean by that? I've already said you have to walk through the front door of the hospital. So I want to sort of temper how low barrier we try to advertise ourselves as, but we do see people as walk-ins. We offer phlebotomy-based testing for 4th generation testing or RNA testing. And then we also offer rapid testing, which we do on a finger stick. It's a 3rd generation ELISA. And that can be done as part of a visit. People can just walk in and ask for that. People can see us for PrEP only. They don't have to be seeing us for SUD related care or want treatment for SUD. We really encourage people to come in for harm reduction services too, including just to pick up injection equipment. We offer pre and post exposure prophylaxis. Currently, we're offering oral regimens only in FasterPass, but we are in process with getting long-acting cabotegravir launched. And actually, I just heard that it passed our P&T committee last week. So hopefully getting going on that in the next month or so. That's been in the works in the background for a little bit now. And then we offer low barrier HIV treatment. So we have several of us that do HIV medicine. We have joint ID and addiction fellows that spend time with us. And every once in a while, particularly with folks with new diagnoses of HIV, it's best for them to continue getting care in our bridge clinic until other pieces stabilize, and then moving them on to either the primary care clinic or the ID clinic. And then this is just a short list of some of the medications that we stock in our clinic. You can see that we have medications to treat sexually transmitted infections on site. We do a fair amount of that. We offer emergency contraception. I have supplies for wound care if we need to do an INT, for example, and then medications to treat withdrawal, including benzodiazepines, clonidine, methadone, buprenorphine. Oh, and I see a question in the chat about IV antibiotics for endocarditis. Yeah, so great question. We have piloted a single case of a patient discharged with a PICC line who followed with us in our bridge clinic. And it's something that our colleagues at the Brigham do a lot more of, and I think it's an exciting space that we would love to think about growing into. None of us is ID boarded that's working in our clinic right now, so we haven't really tried to move OPAT type care into FasterPass, but definitely work with OPAT very closely and offer as frequent as daily visits for line assessment and just checking in on the use disorder when that's something that we can do to be helpful. So I thought in the next couple slides, I would share just a couple of lessons learned over our last 6 years in terms of how we landed with the services we're offering today. I think the first one I'll emphasize is that low barrier means really low barrier. And this has really been a journey for us in understanding what it means to be low barrier. When we started, for example, and it's just kind of incredible to think about how much has changed in the last 6 years. We really thought we were so low barrier by doing a first day nursing intake and labs, and then not even offering medications until day 2. Patients came to see us 2 days in a row, first day nurse, second day provider with prescription. I guess maybe at the time that was a little bit edgy, but totally inadequate in the era of fentanyl, and really rapidly shifted to same day MOUD, medication first approach. And had some data to guide us, which included data from patients discharged from our hospital who were referred to FasterPass. And what we saw, and this was a paper led by one of our fellows at the time, that when we see people the same day as discharge, we see them 82% of the time. And that drops off very precipitously as we get to a day after discharge and 2 days after discharge and further as you get further out. So on demand means same day in our patient population, and we really needed to sort of reorganize our structure and make sure that we had the access and we're balancing scheduled visits with maintaining that capacity to just always say yes. Saying yes is sort of a culture piece that we really work on, where if someone calls us, a patient is having a problem, the patient needs support, we try to just say, yes, we will help you come to a solution today, or get what you need. And that has meant a lot of changes in how we structure our templates and staffing and things like that. We also learned early on that PrEP is still fairly new, and a lot of our team trained before tenofovir and procydamine was even FDA approved for PrEP. And so early on, 2016, 2017, we really focused on teaching and on developing tools that could support people in the moment that may have trained prior to PrEP being FDA approved, or just may have not had much experience with it, which is frankly many of us coming out of training. So we worked on some teaching sessions, we did a grand rounds, we did scripts, and these photos are just photos of sort of sample scripts that can be used to assess injection related risk, as well as sexual risk among people who inject drugs, using open-ended questions, framing questions in a way that normalizes a positive response. For example, how long ago was the last time you used a needle after someone else, or you went second, as opposed to, do you share needles, or worse still, you don't share needles, do you? Because no one's going to say yes they do if the question's framed that way. So lots of good conversations with our interdisciplinary team. We also set up a couple of EMR changes that I think really have facilitated doing PrEP work. That included a standardized lab panel that included the PrEP baseline labs, and then also note templates to prompt our providers to do the HIV risk assessment. That standardized lab panel was a huge help for us because it also let us look at our population's needs more systematically. And so this work was led by Dr. Leah Harvey, who is one of our ID addiction fellows. And essentially what she looked at was first 9 months of 2017, all of the lab results for patients coming in for new patient visits. And we found, not surprisingly, that chronic viral hepatitis as well as HIV are prevalent in our cohort, but also that we were identifying new infections. And in this cohort, there was just one new HIV infection. If you remember the slides about the Boston cluster, this was really prior to the increase in HIV infections in Boston people who inject drugs. But still, I think, identifying a single infection is incredibly impactful in a small network. Lots of bacterial STIs that require treatment and lots of viremic hepatitis C. And so this really convinced us that it was not good enough to say we're a medication first clinic. We prioritize the buprenorphine initiation and then we hand off. That just wasn't meeting the needs of our patients. The needs are more integrated and more complex, and really pushed us to think about making infection-related care, prevention, treatment, screening, linkage, a standardized part of what we do. And as we launched this, we ran into some clinical challenges that I think will be relatable to other people doing PrEP. The first being that the CDC guidelines were not written for our patients. They often address discrete risk or discrete episodes of exposure. And our patients were coming in describing incredibly high risk ongoing exposures, using a needle with visible contaminated blood with someone that is known to have HIV infection, but it happened 5 days ago. Or sort of continuous exposure to partners of unknown HIV status, transactional sex with or without condoms, and injection risk. And we just found that we were getting into clinical scenarios that felt sort of scary or uncomfortable or new. And in that initial visit where there's a lot to tackle, any angst or just concern like that, it can be enough to say, oh, let's address the PrEP next time, and then we miss the opportunity. So we realized that one of the specific things that was feeling scary to us was the issue of the HIV testing window period, because patients were coming in saying they'd had an exposure, let's say 4 days ago, 5 days ago, outside of the typical eligibility period for PEP, which is 72 hours, and yet an exposure that's extraordinarily high risk. So a true example from our clinic was I used a needle with blood in it from someone that I know has HIV 5 days ago. And so then what do you do, right? And so the guidelines would have suggested at the time serially testing, sending an RNA test because of the exposure within a month, and having patients return. But that plan depends on patients being able to avoid ongoing risk. And so it really just wasn't meeting the needs of our patients who had ongoing high risk exposures and were not in a position to necessarily avoid risk for a week or 2 weeks and come back and retest at a time that we could then consider the HIV test to be likely to be accurate. So we felt like that was really a clinical dilemma that we thought about a lot. And to get around that, we started encouraging PEP beyond 72 hours in cases where we were just too scared to initiate 2-drug pre-exposure prophylaxis with an immediate transition to PrEP in patients who became negative. We also offer immediate 2-drug PrEP starts in those situations with a shorter prescription and serial testing if we think that's going to be a better fit for the patient's needs. And of course, there are occasions where if we're really concerned about acute HIV or there are other active issues, we might defer the start and do serial testing without a medication start. But we've really tried to emphasize that is in third among these 3 options. And to the extent possible, we want people leaving with a prescription when they leave our clinic. That means that occasionally people leave our clinic with a script and turn out to be HIV positive when testing returns in a couple of hours. To date, we've always been able to find those patients. And so we've also really worked with our team to normalize that we have the resources to track people down. We work closely with our field epidemiologists at the Department of Public Health, and worries about phone access and being able to reach patients are just not an excuse for not testing and not doing this work. So I feel like we've come a long way in terms of culture, but we'll just add that this is an ongoing challenge for us. And as we hear about things like transmitted NRTI resistance in the HIV cluster in Boston, which has been of concern, these conversations feel more or less acute. And as we look towards long-acting cabotegravir for PrEP and the testing requirements, we're going to have to really, really rethink our testing approach. And so, that brings us to sort of the most recent considerations, which have been related to the pandemic. As I mentioned, we were able to initiate buprenorphine by telemedicine for the first time, which was fantastic. We found that it was tough to do PEP and PrEP for our folks by phone, just related to lab access and ability to communicate about lab results. And our patients also needed the on-demand walk-in access to medications for opioid use disorder, even during the height of the pandemic. So we stayed open. We had our in-person hours, we actually expanded during this time, and also converted about half of our volume to telemedicine. And tried to partner with some of our colleagues that were doing street outreach to reach people experiencing homelessness that might not have their own phone or a space to do a telemed visit. And I learned some interesting lessons that I won't go into too much detail, but we'll say it was pretty interesting, and I think humbling to see that doing telemed in collaboration with street outreach teams was linking us to patients that would never walk in the door at our hospital. And so it brought us to patients that we hadn't served yet and really wanted to be able to reach. And I think was just another lesson that you can only be so low barrier in a hospital setting, although we're trying to get lower barriers still. We also looked at PrEP delivery during the pandemic. And so this was a project led by Dr. Hanan Braun, who is now an addiction fellow at Brown and wrapping up his training. And what we did was we looked at all new patient visits. This was for all substance use disorders, including alcohol use disorder and non-opioid SUDs. And we looked at how well we were doing assessing an HIV risk. What we found was that most of the time we were assessing injection risk. That's good. Most of the time we were not assessing sexual risk, and that was less good and really important for us to understand as a team. And we found that when patients were identified as eligible for PrEP, most of them were being offered PrEP, and about 20% were being prescribed PrEP. Some of that was related to patients declining PrEP. Other times it was related to competing priorities in the visit, but about 20% of those offered were prescribed. We didn't see differences by race, ethnicity, or other demographics in terms of who was offered and prescribed. And we saw that most PrEP and PEP prescribing actually does happen during the first visit, sort of contrary to this concern that there's too much going on in the first visit and it's adding one extra thing that is not manageable. When we do it successfully, it's often that first visit. So I think that has sort of emboldened us to continue to emphasize PrEP, even in the setting of multiple acute issues like overdose prevention. And we found that we were offering PrEP to people who inject drugs, even who lack CDC eligibility criteria, which I think is important. And I think just shows a feeling that many of us have probably had, that the guidelines fall short in our patients and don't account for issues like incarceration release with return to use, or recent relapse with return to use, or a new partner who may have HIV or be of unknown HIV status. So, I think important to think about from an advocacy standpoint, how we can create guidelines that are better tailored to the needs of our patients. And we'll just also comment that in reviews of this paper, when it was going through review, one of the reviewers that stood out said, 20% prescribing, that's terrible in the setting of an HIV outbreak. And it's too low, it's way too low. And we know that baseline uptake rates are between 0 and 3%. And so we're both proud of this work and also recognize that we have so much progress to make to get PrEP to everyone who stands to benefit. Other adaptations for us have included updating our HIV risk assessment tool. So we weren't assessing sexual risk well enough. We've updated our our EMR note templates to prompt us to do a better job there. We have implemented the rapid testing for patients that decline phlebotomy. And that's a real issue for our patients with difficult venous access. Phlebotomy is often painful, sometimes not even successful. And so, having the rapid testing option has been, I think, incredibly helpful and demonstrated responsiveness to what our patients are telling us is a barrier. We are recommending testing monthly in our setting because of ongoing high transmission. And if someone lacks a phone, like I said, we have resources to address that. We don't want people missing a chance to test just because of concerns about reaching people on the back end. So I'll do just a couple minutes about our low barrier methadone protocol and then pause for questions. So this, as I mentioned, relates to the 72-hour rule. We learned with our legal team and in collaboration with our pharmacy colleagues, our emergency medicine colleagues, that we actually had the infrastructure to do this in Faster Pass in an outpatient bridge clinic. And we piloted it in March of last year. Our first case went incredibly well. We were so excited. We'd never, administering methadone in an outpatient clinic to us felt so novel, so exciting. Our patient had never been on methadone and was not as familiar with the methadone system. And so I think that all the fanfare felt a little bit surprising, but we were able to convince the patient that it was really exciting. she was treated for 2 days in our clinic and then linked to an OTP and has done incredibly well and sustained linkage at the OTP. And that really made us feel like we could do it and that there was something here that was meeting a need, and demand for our pathway grew rapidly. I included these photos of our protocols just to remind me to share that we have published our protocols if people are interested, and I'm also very happy to share them. And what's been great to see is that this pathway is pulling in patients that we weren't seeing before, including people at incredibly high risk of HIV infection. In our first cohort of 142, the HIV prevalence was 15%, which is really many-fold higher than what we see in our program overall. And lots of risk, fentanyl and poly substance use, including stimulants, many of our folks experiencing street homelessness. And this really hit a nerve in our community, where access to methadone, when I give talks about this, I always say I could hit a baseball to 3 methadone clinics from where I'm sitting. We are in a high resource setting in Boston. We have a lot of services, and yet patients often wait 1 to 2 weeks to get into an OTP. It's too long. That is a length of wait that can lead to death. And so we started this protocol, and we expected some interest and some demand. I have never walked into my clinic though and seen a queue at the door. And last summer that was happening. You would turn up at 8 o'clock, there were people sitting outside our clinic waiting to see us for same-day evaluation, same-day methadone withdrawal management, and direct admission, rapid linkage to our opioid treatment program partners. And it exploded. And so there were some operations challenges related to the rapid growth of our volume. Here, I'll just emphasize that through working with our OTP partners, signing affiliation agreements, we've been able to link people successfully. We secure that plan within 3 days, so we're practicing in compliance. It's been a really great thing to be able to offer to patients who otherwise would wait 1 to 2 weeks to get into the OTP. And we found that our patients are both linked, so 86% actually attend that OTP appointment, which is incredibly high when we think about the barriers that our patients face, street homelessness, multiple co-occurring use disorders, undertreated psychiatric morbidity. And that those who link have very high retention rates. Of those who link, 67% are still at the OTP at 1 month, which as far as we followed out the data, which was really exciting to us. So we think that this is not just treating withdrawal, but actually leading to sustained engagement in methadone treatment and all of the benefits in terms of overdose prevention and HIV prevention. The other thing that's been really, I think, fun and exciting about this pathway is that on the one hand, we're not an OTP, and that's really hard because we can't keep people for a 4th day. On the other hand, we're not an OTP, and so we can treat patients with the dose that we think is appropriate, and we are not bound to OTP dosing guidelines. And so we found that as our comfort has increased, and also as we've just seen that our patients are coming back day 2 with a really high COW score, we've been using higher doses of methadone. We treat a lot of patients with 40, 50, 60 milligrams if they have high tolerance. We're also incredibly cautious and concerned about the safety with methadone. But I'm happy to talk more about that if folks are interested. Why don't I pause there just to have plenty of time for questions? And I'm happy to talk a little bit about what comes next for us or discuss any aspects of what's been going on so far.
Thanks for just a fabulous talk and such important work, and you have been disseminating it actively. So thank you so much, Jess. I wanted to take the opportunity to ask just one question that came up in the chat is how much is concerns for resistance coming up with PrEP in this population if they're going on and off PrEP and they're obviously exposed based on their injection drug practices?
Yeah, no, it's a great question. And as we look ahead to long-acting cabotegravir, I think the concerns about the potential for developing resistance really become much more challenging. We have seen transmitted resistance in our cluster. We had a couple of cases of 3-class resistance in 2019 that was transmitted in our Boston cluster that were just incredibly scary genotypes. We have not seen very many genotypes that would render tenofovir and emtricitabine ineffective as PrEP, we don't think. And so we're kind of taking the approach of cautious retesting, serial testing when people are on PrEP. We recommend testing monthly. And so that's different than guidelines, which would say to test at least every 3 months. We have not had patients seroconvert and have barriers to being on a first-line HIV treatment regimen related to PrEP use. But we have had a lot of cases where we start PrEP and then someone tests positive either weeks to months later in the setting of incomplete adherence, or later that day because we had a test that was pending. And it takes us a couple of days to get them back, or maybe there's a couple of days of unopposed tenofovir and emtricitabine exposure. That scares me because it doesn't actually take that long to accrue NRTI resistance mutations in the setting of 2-drug exposure. And I think that at a population level, we do more harm if we're too afraid to prescribe PrEP and PEP. So we're kind of always balancing these risks and thinking about ways to mitigate them by saying, see me next week for retesting, see me in 2 weeks, doing a 2-week prescription. We're super lucky that our pharmacy is willing to break a bottle up and dispense less than a 30-day supply, which can be a challenge at commercial pharmacies, but that's something that's helped us feel comfortable. And we have resources in our community partners that we refer to as well. So Healthcare for the Homeless, for example, has a very robust DOT program where their teams actually find people in tent encampments on the street and try to do daily DOT for PrEP or HIV treatment. And so we really try to leverage those community supports as much as possible.
Thank you so much. I have a bunch of questions, but I want to turn it over to our discussants. Dr. Meyer?
Thanks. A great talk. Jessica, it was just so interesting to hear about all the amazing work you're doing and all these supports that you're giving people and access that you're giving people who wouldn't necessarily normally want to be seen in like our traditional clinic settings. And they're certainly not going to present to a sort of a classic PrEP clinic, and wait in the waiting room for an appointment. So it's so great that you can provide these services. I just had some questions about sort of the, I guess, more practical aspects about like how people come to you, how they get in the door, and about how long they stay with you, because it sounds like you're kind of, as you said, bridging. You're starting them, and then they sort of continue on in care with your community partners. Just wondering kind of how long they stay.
Yeah, it's a great question. Thank you very much. And it's changed a lot during the pandemic. Pre-pandemic, our average length of stay was in the 20s to 30s of days. So essentially a couple weeks. When we looked at it during the pandemic, we were having just a much more difficult time passing people on because of limitations in other programs. And our average length of stay was up to maybe 55 or 60 days. We haven't really looked at it since in the last 6 to 9 months. So I would guess that right now what we're seeing is kind of a bimodal distribution where people that see us for 72-hour oral methadone by sort of necessity see us for 3 days and are then linked. And those that are seeing us for buprenorphine are staying with us longer, more like a couple months to or weeks to months. But we do encourage people to come back. So for example, if we treat for 3 days for opioid withdrawal with methadone, we link to the OTP. Our OTPs very often don't have integrated PrEP services or medical services. And so you can still come back to see us for any other reason. So we might start the PEP or PrEP, 3 days of methadone linked to the OTP. Actually, I was doing that this morning. And then say, come back next week and we'll repeat your testing. We'll see how it's going with tenofovir and emtricitabine. And we can continue to bridge other issues until we pass people on. Typically to one of ourselves. So we're lucky that we it's both a blessing and a curse that we have a lot of providers that work in our clinic. It makes the staffing model complex. And we have a lot of providers that do primary care, or either in the HIV clinic, in the general medicine clinic, in family med. And so we can try to pass people on to at least known providers, maybe even someone that they've been able to see in Faster Pass. So it varies a lot. And like I said, our longest running patient, September of 16, and still comes in to see us. So we try not to ever say never, but be flexible when we need to.
That is so much more than a bridge. That is, it might be initiating someone in care, but that is so much more than a quick bridge. So that's great to hear.
Very patient-centered. And Dr. Barad, I know you're here. Would love to hear your reflections and any questions you have. Thank you so much.
Yes, thank you, Jessica. That was a wonderful and great presentation. And I'm just going to focus more on the prevention or PrEP side, because that's really where my work is focused on. And just to share with you that we had a similar program or thought about implementing, how to get people tested. So the first thing is access, and great that now we have other avenues for people to get HIV testing. It's been an interesting journey here about who's willing to do the testing and who's not willing to do testing. And so we've partnered, like you have, with your emergency, with the emergency department here, in order for us to increase the screening and the linkage into the healthcare system. And I just wanted to ask you, because this is what sort of we got feedback from trying to establish this program, which, by the way, it's still ongoing. So one of the things I wanted, and I think you addressed this, is the sustainability of your program. And then I wanted to figure out what were the barriers from your provider clinician standpoint in terms of implementing PrEP, and particularly you're doing same-day PrEP, because that always comes up in the literature. Is it more acceptable? You know, even from a patient perspective, is this method more acceptable to them than going to their primary care person, if that's not you? Things like that. And then finally, I must address this because it's now an issue for our PrEP patients, is the cost and who covers the prescription. Thank you.
Yes. Call me out if I forget any of the questions. Let me answer the last one first, because that is really on my mind right now, is cost. We're incredibly fortunate that our state Medicaid coverage is very robust, including for PrEP. And so we're anticipating, for example, addition of long-acting CAB to the Mass Health formulary, and for our BMC HealthNet formulary to follow. If someone has one of our ACO plans or a state Medicaid plan, that is the most straightforward scenario that we deal with in terms of coverage, and really we don't have cost-related barriers. Where we are really struggling is people with private insurance and high deductible plans. And I think a real fear for us is with the new PrEP guidelines and the increase in RNA testing, it's not a settled issue how that gets paid for. So we're actively advocating with our state Department of Health for the state lab, which is free regardless of insurance status, to cover that RNA testing and really address that cost barrier. And we do have a navigation team that works with patients around patient drug assistance programs and PrEP DAP, which we have in Massachusetts, and just other, other supports. And we're able to get almost everyone PrEP at a reasonable cost. But I think the new guidelines in cabotegravir will really challenge us on that front, and I'm worried about it. Another major facilitator for us is that our in-hospital pharmacy is a safety net pharmacy. And so copays are waived for patients with state Medicaid. And so that has really, even the, a $5 copay can be the difference between getting PrEP and not, and being able to waive that on site has been incredibly helpful. I forget your second question, so I'll answer the first one about sustainability, and then you'll remind me what I forgot. Sustainability, so this keeps me up at night because we have this big team, and it's so incredibly important that we continue the services, that we grow the services. And so we right now have made a partial transition to supporting ourselves with revenue. At this point in FasterPass, most of our provider time, not all, but our weekday provider time is sustained through revenue, through billing and RVUs, and we get there, which is a little bit scary sometimes because we're a walk-in clinic where volume isn't guaranteed the way it is in a scheduled clinic. But we have parts of our programs, such as our nurse care manager time, our program manager, our navigators, that will not be able to generate enough revenue to cover the costs of salaries. And so that's where we continue to go after grant funding. We've had incredibly generous support from our State Department of Public Health that is renewing us for another 2 years. And some hospital support. And so, we sort of piece it together, but I think we have a real problem with programs like ours, which is that we can create services that are innovative and meet patient care needs. And then the question is, how do you make them, keep them in the black and make them sustaining? So that is definitely something we think about. And we've done a lot of work with our strategy team to try to map out for stakeholders what the financial benefits of our program are in terms of decreased ED utilization. Just one example from our methadone cohort, that first 140 that we looked at, that group had 200 fewer ED visits in the 6 months after their 72 hours with us compared to the 6 months before. And so we're starting to show numbers like that really, can get people's attention in terms of ACO level cost savings, throughput benefits to the emergency department. But it's been an education for me to learn to have to sort of talk that talk and think about those other financial benefits like laboratory revenue, decreased length of stay if someone can be discharged to FasterPass on a Friday for withdrawal management over the weekend and go to the OTP on Monday, as opposed to staying in an inpatient bed over the weekend when it's not medically necessary. So anyway, happy to talk more about that offline because it keeps me up at night. And now I can't remember your second question.
if anyone has other questions, please go ahead. We could discuss this offline because there's a lot that we have in common. So
thank you so much. And I see we have just 1 minute left. And so if folks have to hop off, feel free. But I know Alex Dittmore here is on from Connecticut Harm Reduction Alliance and is on the front lines and has provided some great comments in the chat, and just wanted to give her the opportunity to share her experiences. And Alex.
Hello, I'll be quick since we have a minute. So I am a program director for the Connecticut Harm Reduction Alliance, and I oversee a low barrier drop-in center, as well as all of our HIV and hepatitis C screenings. So though I'm a program director, I have very much direct care service. And this was very, very, very helpful for me to see, because I already work with Dr. Edelman for a grant specifically around PrEP for people who inject drugs. And that's what we're working on. And it's so difficult. We're seeing huge clusters of hepatitis C popping up and things like that. And one of my biggest things that I saw that you talked about was methadone, and addressing the fact that fentanyl is very different than heroin. So we need to look at dosaging differently. The only thing I just always want to bring to the table is the increase in tranquilizer and benzodiazepines being found in bags. So I'm seeing people that are being turned away from programs because their urine is showing positive for like a benzo or things like that. And there's only one facility in our state that will actually treat you if you have like a benzodiazepine that comes in the urine. But I just wonder what that's going to look like with the future when we talk about poisoned drug supply. I mean, like, how does that work for providers within ethics of what you're allowed to do as well, working with it?
Yeah, no, thank you for that comment. We are seeing benzos, synthetics, you name it, in everything too. What we've been able to do with our OTP partners is if someone has a benzo use disorder, which is actually more straightforward than the issue of contamination with synthetics, our partners will accept patients as direct admits at the OTP, and patients will return to us, and we will do a benzo taper if needed. If someone has a severe use disorder and needs a 4 to 6 to 8 week taper, we've done a few of those on a case by case basis. And I think that's sort of the value of that 72 hours in a clinical medical setting, is you get to address the other active issues that are barriers at the OTP. Maybe it's cellulitis, maybe it's benzo withdrawal, maybe it's alcohol withdrawal. All those things can be addressed pretty readily if there's a high touch model where you can get access to a provider, to a nurse care manager. And so it's a handoff to the OTP, but it's also often the ongoing addressing of other issues.
So I just want to thank you, Jessica, for such a wonderful talk, sharing all your important work and so clearly. And it's so inspiring to hear how well you guys are meeting the challenges of this of the population. So thank you. Dr. Meyer, Dr. Barada, thank you for your comments, and thank you all. Sorry to keep you past 2 o'clock, but so glad we had this opportunity. Thank you so much, everybody.
Thank you so much. Wonderful to get to talk to you all.
Thank you, Dr. Taylor.